The next half of this presentation or this section will be discussing on the roles of patients advocates in setting up the stage for potential patients that going for stopping treatment. Of course, that you can see from the discussion that it is still not feasible to do a stopping treatment outside a controlled environment. But the reality is, has been discussed by the speakers, that there is some situations where patients stop treatment on their own or even driven by the physicians. So with that, I think we need to look into this matter very closely. So I would like to make an analogy what is stopping treatment in this case. So it's something like setting a stage. What is that stage? Okay, you imagine that you are having a concert, big concert. You have a stage, we have the performers, you have the instruments, the musicians, the audience, and the promoters, the crew, and even the ticket sellers to make success of the concert. But in this interest of stopping treatment, I think the performance is the stop trial. Okay, we need an instrument which is the TKIs and the monitorings, and the audience are the patients who are of interest. Okay, you yourself as the advocate is the promoter. You can become a promoter to give a true pictures of stop trials. I mean stop treatments issues for them to get a clearer pictures. The physicians could be the crew of this whole situations and family support. So I would like to get for you to more engage in these situations. You have a big roles, as a patient advocates to play a role. What can be done as a patient advocates. So for that, we have 3 advocates from Indonesia, from Korea Park, and third one Sundar from India. So Andrian, I can see that Indonesia has been struggling to have access programs, get into the medication for every patient, even the monitorings. Okay, at least you have gone through a big obstacle of getting more patients to get treatment. Can you share a bit with us about the background of situation, whether in your country has this issue been well discussed or widely discussed among the patients, or any patient that has asking their physicians to stop treatment?
Thank you very much. Yeah, my name is Andrian. I am CML patient from January 2011. Just like the other patient in worldwide, that stop treatment had already discussed, of course, but common trait found in illegal patient in Indonesia, there are some patients stop treatment not because clinical trial. First, they don't know what is CML. So there are patients who still reducing the doses prescribed by their physician or stop treatment, and the reason is because they feel the feeling of healthy and healed only from CBC days. The second, mostly patient very scared to stop treatment because will cause a relapse, of course. But if they are resistant to imatinib, we can go to nilotinib. But if we resistant to nilotinib, there's more difficult access to therapy, because in Indonesia there are only 2 types of TKI, imatinib and nilotinib. According to our physician perspective, our hematologists say that not all laboratories can conduct this kind of molecular analysis because, we have limited resources. Second one, they said ELN 2013 has not been applied yet in Indonesia because there are limited capabilities in laboratory, and even there is a laboratory to who can conduct this analysis. It's still very expensive and not covered by our GKN or guarantee assurance, our guarantee assurance in Indonesia. And the third one, our position said that stop treatment is still on the research. So they said we follow the rule of the worldwide. So they not suggest us to stop treatment.
So all in all, I would say that in Indonesia, the problems of stopping treatment is really outside of a clinical trials, right?
Yes.
So there's
yes.
a lot of patients that we may not know that they are
Yes.
stopping the treatment.
Yes,
So
there
do you, what is the role of patient advocates like you?
Okay.
I mean, you are passing the message to them.
Yeah. What LGK concern now is not about stop treatment exactly, but we concern about how patient can access to treatment throughout in Indonesia, because there are only a few hospitals to patient who can access to the therapy. So I think LGK doesn't yet to
So what you're doing is like trying to create a good foundations to give education to your patients to remain compliant so that they can get a deeper response, a long
Yes.
duration of response
Yeah.
before thinking of
Yes.
stopping the treatment.
We concern about first access to therapy throughout in Indonesia. Second one is of course awareness and education about what is CML.
Okay, thanks, Andrian. Maybe India, Sundar, you have, India has very much thousands of patients with CMLs, and of course, this is also a problem in India. I mean, you want to share your experience with your patients?
Yeah. So I'm a caregiver, and my wife detected CML in 2002. I think till about 10 years now, she's almost undetected is the result. In fact, I was thinking it was close to 0 point something, but it's not even that. So I've been urging her to stop treatment last 3 years. So I think, why don't we stop the medicine? Because the concerns have is the long-term damage due to the TKI. 1, 2, again there are mild side effects, which is like eyes would have water retention. So these are my concerns. But of course, every time the doctor advised not to stop the treatment. And of course, my wife is terribly scared to stop treatment. Probably she is 100% compliant or 105% compliant. She would even take the medicine on the second exact time every day, very, very particular. So unfortunately for her, I'm a risk manager by profession. So I said, oh, don't we take a risk? But I think it's, from what I understand now, it's too risky. And I guess it's even the people who stop treatment, it's 50% or 60% succeeded. So what we've done as patient advocates in India is we actually get the medical panel done for various patients and advise them on compliance. Compliance has been the core to patient advocacy. So we've advised people to take medicines on time, not to miss medicines, 1, 2. Also, the questions of stop treatment, we've advised so far no. But where there are side effects, and I know of cases where there are side effects, the doctors have supported outside of clinical trial to go for stop treatment. And of course, like the garlic incident, which is in Australia, we have also interesting cases in India, where people have tried native medicines and other medicines. And I've known 2, 3 miserable cases where it's backfired and relapsed, and then death also. So the risks are too high, And so, as a position as it is that thing as advocates, we would not advise people to stop treatment, and of course, strictly on the advice of physician, the treating physician or the treating doctor, who would need to advise necessarily. So that's the position, and there is no clinical trial ongoing. Where I've known cases where people have stopped treatment on the advice of physician. I think they are doing regular tests, monthly PCR and even BCRA, I believe, quarterly. So that they are on the safer side. I guess more due to side effects of medicine rather than the positive aspect of stop treatment, which is going to dream or a near 100% normalcy from near normalcy, I would say. So that's the goal, but so far I think the data and the risks are far more. So wherever it's mild side effect, near normalcy, the physicians are advising do not stop the treatment. So that's the position in India.
That's a good thing. I think the situation might be a lot different in Korea. Maybe Park, you aware how these patients in Korea who's been involved in stop trials? Of course, there's some of them, willingly want to involve in the studies, and what are the reason of joining or not joining into the trial? Do you want to share some experience?
Yes, we have ongoing trial in Korea. About 150 patients are in the trial. Now, some people want to be in that trial because they want, like young lady, they want to have a baby. And if one person have a severe side effect, he wants to quit the drug. But now, every Korean patient cannot if he want a stop trial, he cannot get in there because only one hospital is doing that stop trial because it takes a lot of money to do that clinical trial because everyone has to be tested, PCR test frequently. So our government paid a research grant for one doctor, and now the hospital which is doing the clinical trial stopped recruiting newcomers because they used all the money. So they are waiting for another research grant. And some people want the clinical trial, but some doctors do not want them to recommend to get in because they do not, some doctors are conservative still. Like if a patient get in trouble when he stopped the trial, some doctors do not want that kind of trouble. But many people know about the stop trial in Korea and Japan because we share the information using our website. And if I go back to my country, I will share the presentation of Dr. Ross and Dr. Wong in our website. And now we know much about the situation of stop trial in Korea and worldwide.
Oh, that's good. It's good efforts that you share the trial information within the groups. Oh, okay. I think on the physician side, Dr. Ross, Dr. Raymond, or Dr. Sansuri, anything you want to add? I mean, what can people like us, maybe, of course, you have something that need help from patient advocate. So is there anything that you could ask from us, offer us to do as part of the...
Well, I mean, I think we've heard from everybody that the major thing is money and the availability of the testing, because really if you attempt treatment-free remission, you're exchanging the cost of the drug for the cost of the test. And the problem that a number of countries have is that the money for the drug and the money for the testing are separate. Because if you could transfer the money from the drug into paying for the tests, there would be no problem. But there's a complete disconnection between how the test is paid for and how the drug is paid for. So this is the real problem. If you want to make TFR a possibility in every country, then whoever is now paying for the drug has to take the money that they save in not giving the drug and put that money into providing safe testing. That is the major problem that I see. And you know, in Australia we're fortunate that there's no limit on the tests, because if there were a limit on the tests, we couldn't do the things that we've done. And really, we've estimated that the Australian government has probably saved $2 or $3 million from the 40 patients who stopped in our study. That would pay for every test to be done 5 times for every single patient. So there just has to be this matching of the drug money and the test money.
Yeah, Pat, you want to say something?
Pat, yeah. I know you.
Thank you. Before the session ends, because I think this is a very important session, and I want to make sure that we take a moment to think about what we are going to say to the people in our groups when we go back to our countries. I have seen people that attend these meetings, they attend CML Horizons, they hear from the doctors about stopping. They hear it has to be done in a clinical trial, they hear there's the risks, and then they turn around and don't give the right message to their members. So I think that we have a big responsibility of what we do with the information. Everybody's very excited about stopping. And especially because in Facebook and in social media, you see the people that have stopped. A lot of the advocates, maybe from Europe, that have very good setups and they have clinical trials and have stopped, and everybody's very excited. And when somebody stops successfully, they get some kind of a status of super cool, and we all want to be like them. But we have a responsibility to make sure we don't let the patients in our country take risks. In most of our countries, there is no good access to PCR. We know this. We know in our countries there's no access. So we know nobody should stop. So if some member come to you and say, should I stop? It's not, we're supposed to not give medical advice, but we can make sure that we say, in this moment in our country, we shouldn't, right? So as advocates, let's make a plan. What is it that we can do so that in the future, people in our country can perhaps stop treatment if with the help of their doctor? And one of the most important things I think that we can do is to figure out how to better advocate for access to good quality PCR in our countries. We should make a plan. How are we going to bring or help bring PCR to our countries so that when we're ready and the clinical trial can come, and then we can have the possibility of some patients stopping. But I think this is very important. We are not here to talk about our own selves. We are here to represent the members that are in our countries and to do everything we can for them to be able to safely live with CML. So I just wanted to make sure that we say that out loud so that it's very clear that what the message is at this moment.
Yeah, I guess we could run a campaign where how to stop treatment safely, something like that. So by like going back to the foundation, getting adherence and compliance, monitoring all those things. Dr. Raymond?
Select what the patient selection issue, okay? So, and that is again another risk management issue, okay? From all the trials that we know, from Dr. Ross' talk, we know that if the patients can be maintained on a good molecular response for a longer period of time or deeper response, you know that the outcome will be better. So with that in mind, so if you have only limited resources to help a few patients, then you can sort of adjust your criteria. Maybe I want the patient to be MR 4.5 for 4 years before I stop the treatment. Now that will guarantee a slightly better outcome, okay, based on all the trials result, that will probably point to a better result. And probably that will limit the patient number that you need to monitor a little bit and let you get a little bit experience. And that can be done, certainly outside a clinical trial. But the problem is that in real life practice, because we are so busy every day, so if we don't have the system in place and make sure that the patient is safe, we should not do that. Okay, that's the bottom line. So patient safety and benefit always our top priority. If we cannot make sure that this can be guaranteed, don't do anything. Okay, keep the patient on treatment is better than stopping the drug, in that sense. Thank you.
Okay. Yeah.
One question, Ron. The next one.
This is the hot topic.
I have a question for Dr. Wong, because I'm trying to marry the economical constraints of having monitoring every month as against the medical reasonable time that we can monitor. In the studies you presented, what is the least evil that could happen? Meaning, for those patients that relapse and then went back to the TKI and then progressed to a mutation, what is the fastest time that it happened? Because if we were saying we must monitor every month, but there's the economical constraint. The ALN guideline says we should monitor every 3 months. What I'm saying is, if according to all the studies you presented, the fastest that the worst could happen is 4 months, then we could go with the 3 months monitoring for stopping treatment, and we'd still be there. There would be no economical constraints because it's 3 months as if you are just following the ALN guidelines.
Can you compromise on that?
Yeah, so I think once you stop the treatment, okay, in some cases you don't need to wait for 3 months before you see the sort of molecular, the BCR-ABL coming back. So that's why we want to do it monthly, because what we know is that within the first 6 months is the highest chance that you got the disease come back. Okay, so that's why you want to monitor really closely and start the treatment as early as possible, not to wait until the disease has got the full relapse, okay, and then you start retreating the patient. Because as I've mentioned, if you got the full disease relapse, you got more cells, there's a high chance that the disease may progress or develop other mutation. So that's why you want to keep the treat as early as possible. Now, after you basically put the patient, say, with this patient really relapse, put back on treatment, then I think to me, if there's a resource constraint, I will monitor them 3 months after the treatment, because it's just like a patient started on treatment the next few years. Thank you.
Okay.
From the patient advocacy side, what we could do is set up FAQs, Now, the priority in India, one of the interesting aspects of India is the testing is not that expensive. It is expensive for an average Indian, but there are a lot of people who could afford testing, they'll live in lifelong. So it's not a problem there. But the problem is the risk. His risk is still live for stopping treatment, especially if the side effects are mild or probably no side effects. So when you outweigh the risk, you still have an issue whether to stop or not to stop. There's still that stress. So best that advocacy groups could do is set up FAQs, set up survey results, publish results, educate continuously. And that's what we try to do. I think that's what the priority is. On the other hand, there are lots of poor patients in India who can't even afford the basic medicine. So I think the priority would be to distribute to them, if possible, rather than stop treatment and fund the testing part. So it's a mixed situation.